I would like to thank the organization committee of ASMA to give me the honor of being here to do this presentation. And I would like to thank you, my esteemed colleagues, for being here to listen to it. I'm going to go completely the opposite direction of Dr. Umapathi. Basically, I live in the US and work there, so I'm going to give you my approach to neurology, particularly in ALS. And it's an American-centric approach, but that's all I know. So we're going to do something, completely opposite, but hopefully it'll be useful to you regardless. So for full transparency, here are my disclosure of potential conflict of interest. I am the principal investigator at the University of South Florida in clinical trials sponsored by these various pharmaceutical companies as well as some organization in there. And I also serve as an advisor to PTC Therapeutics and Woolsey Pharmaceutical in designing their clinical trials for ALS. So today I'm going to talk about ALS pathology, epidemiology, and diagnosis. We'll describe and update data on current approved medications for ALS in the United States and describe current ALS trials worldwide. So ALS, or amyotrophic lateral sclerosis, as the name implied, amyotrophy referred to loss of anterior horn cells. So they're localized here, representing the lower motor neuron. And you also, which lead to denervation and atrophy of muscles seen on clinical examination as well and pathological examination. The lateral sclerosis part referred to scarring or hardening of the lateral cortical spinal tract. Those are axons from the cortical motor neurons or upper motor neurons. So in a patient with ALS, you see both signs of upper and lower motor neurons affectation. So in terms of epidemiology, the vast majority, up to 95%, is sporadic, meaning there's no mutation associated with it. The rest, about 5 or 10%, is familial, which means that it runs in family and is associated with at least with one of maybe 30 plus mutation that we know right now. It is pretty rare, so the incidence is 1 to 2 per 100,000, but patients don't die right away, so you have a higher prevalence rate of about 5.2 per 100,000 in the US. And you can see here on this graph, published in 2015, that the peak age is between 70 and 79, and more men are affected than women, so 2-to-1 ratio roughly. The average survival is between 2 to 5 years, but you can see that some of the patients live out a decade or more. So, and you can't predict who's going to do what. So here's what we're going to predict to happen in the future. So from 2015 to 2014, across the world, we're going to see an increase in ALS cases. And that's mainly because of aging of the populations. So by 2040, a lot of these countries will have a higher percentage of patients in the age group of between 60 and 79 years of age, where the risk of ALS is the highest. So it's not just population increase alone. So the disease is defined by a slowly progressive painless weakness, and the initial symptoms can be anywhere in the body. And to make the diagnosis, you have to have both upper and lower motor neuron signs. And about half of the patients would have cognitive impairment or frank dementia. And so that's something that's part of this whole syndrome. In terms of diagnosis, we've been going along with the ALS scoring criteria that was published in 90, and it characterized the disease into 4 different stages, where suspect is when you have lower motor neuron signs only. Possible is you have both upper and lower motor neuron sign in one region. And if you have 2 regions, then it's probable, and 3 regions is definite. And there's some small allowance for other things here too. Notice that this is purely clinical. So if you have at least upper motor and lower motor neuron signs in one region, you got the diagnosis. You don't have to do anything else. But they thought it was inadequate, so the revised criteria in 98 added EMG. So if you can use EMG findings to substitute for lower motor neuron involvement if you can't find that on exam. And then the Awaji modification happened in 2006, and basically they say that fasciculation had the same meaning as fibrillation and positive shock waves. More recently, we're sort of, this is kind of problematic because when you write in the chart the patient had possible ALS, they will say, well, are you sure? And so the more recent criteria is called the Gold Coast criteria, and it classify ALS into ALS or not ALS, make it simple. So first of all, you have to be normal at some point and then have progressive motor impairment over time. And then on exam, you have to have upper and lower neuron signs in one or more regions, or lower neuron signs in two or more regions. And then you have to exclude everything else. Once you met those three things, then you have ALS. In the US, we have 4 currently approved drugs for treatment. Riluzole, which is a glutaminergic neurotransmission blocker. Edaravone, which is a free radical scavenger and antioxidant. Sodium phenylbutyrate, and Terso is a mitochondrial and reticulum signal blockade. And the most recent one is tofersen, which is an antisense oligonucleotide that caused degradation of the SOD1 mRNA. So the reason why we use Riluzole is the fact that in the original studies, patients seem to live 2 or 3 months longer. And when we look at real-world data, looking at all the clinical trials database out there, we found that in some case, the patient lived up to 19 months longer. So that's the benefit. The problem is, who does it benefit? So I'm not sure about the situation in Vietnam or elsewhere, but in the US, we actually don't see these patients until about a year and a half into their course because they normally see somebody else first. So sometimes they come in and pretty sick and pretty far along. Would you give Riluzole at that point? Does it make any difference? So this paper sort of try to sort that out by looking at the original participants in the dose ranging study of Riluzole, and found that if you're in stage 2 or stage 3, meaning that 2 or 3 regions are affected, you make no difference in terms of survival. So placebo versus different doses make no difference at the end and how long you live. However, if you are phase 4, meaning that you're now nutritionally and respiratory deficient to the point where you need a PEG tube or a NIV, non-invasive ventilatory support, you actually do much better than placebo. So you can see here that the patient with 100 milligram a day of Riluzole did way better in terms of survival than placebo and the other 2 doses. So it become an ethical question. You know, if you add add 3 months to my life, I would prefer that you add it to the front end, not the back end. What's the point in that, right? So that's the conundrum that we are dealing with. Edaravone is a second drug that we had approved, and originally edaravone was used as a stroke, prevention of stroke extension damage. So it saved the penumbra. So what happened is that's why they have this weird sort of 14 days on and then 14 days off, followed by 10 days on and the rest of the month off kind of routine. And they never changed that protocol to use it in ALS trial. So in the trial, they found that patient on edaravone at the end of 6 months had a 33% slowing of progression. And based on that data and nothing else worked at the time, the USF FDA gave it approval. And a subsequent study have shown that if you're on drug, you actually live 6 months longer than if you were not on drug. However, this study showed that it didn't make any difference in terms of survival. So they looked at the subgroup that would have met the ASNA2023 trial criteria that show improvement in ALS course with edaravone. They didn't see a difference, and likewise not much with the slow progression of the group that didn't meet the criteria. So this is just fresh off the press. So think about it. Edaravone half-life is 5 to 7 hours and is a neuroprotectant by nature. Does it make any sense if you give it for 10 days out of the month and hope to have a benefit? In the ALS-19 trial, it did seem to have benefit. So what the company did is they actually test this medication on a daily basis to see if they would extend the benefit of IV 10 days a month. And this came out right before I left for Vietnam, that when they did the fertility analysis, they found no difference or no potential or probability of the daily dosing going to surpass the IV cyclical dosing, so they stopped the study. Sodium phenylbutyrate and terso, or AMX0035, is a drug that we test. I actually know the company. There's two college students who in their senior year of college decided to do a little research and find different compounds and see which compound would maybe a potential treatment. So they happened upon some findings that this compound plus this compound and this compound alone made some change in mouse model of ALS. So they combined it and actually ran a trial, and now the CEO of the company. And Amylyx is actually named for one of the founder's girlfriends, Amy. So that's why we have Amylyx and AMX0035. And this was a 6-month randomized placebo-controlled study. It's a phase 2, it's a small study. And we found that it slowed progression by about 25% at 6 months. And if you go out 3 years and look back, survival increased by about 6.5 months. Now, this was a phase 2, and the FDA was really hesitant to give them the approval, but there was a lot of patients pushback. So they gave them the approval with the understanding they would do a phase 3, which they just completed. So they collected 200 patients in the US and 400 in the European Union. So they just finished collecting like 600 and some patients. So we expect the result of that study, confirmatory study, later this year. The last drug that was just approved a couple months ago was tofersen. So tofersen is a anti-sense oligonucleotide. So basically, this is the normal situation. So the DNA would transcribe an mRNA, which then transcribe a protein, and that's what you have. If you have a mutation in the DNA, the mRNA is going to be mutated, and the protein that you transcribe from that going to be abnormal, and it flow up abnormally, and that can be toxic to the cells and cause cells death. So the ASO, what it does is it binds to the mutated area and blocking that function, so that no protein is synthesized. As a result, you don't have that toxic effect of the protein. The study that led to the approval was called the Biennial study, and it's 8 doses given over 24 weeks, and intrathecal. And this was published in the New England Journal recently. And you can see that at 6 months, when the roughly 6 months, 28 weeks, when this endpoint was measured, there's a trend toward improvement with treatment because the progression is lower, but it did not reach statistical significance. For the slow vital capacity, there was a significant separation between the two groups. But the study was considered a failure because they didn't meet endpoint at a pre-specified timeline. Now, to be fair, they could have dragged this study out and measured at 52 weeks where there was actually a difference. The problem is that it's an ethical issue. If you have potentially effective medication, you do not want to withhold it from the placebo group for a year. Because what happened is that the placebo group, when they got the real drug right here, improved. You can see the trend that is slowing down, but they didn't catch up to the patients who actually got drug from the very beginning. So most of the ALS study now, given the short course of disease, limit the endpoint to 6 months rather than anything longer. This is to show you also that, again, in SOD1 protein, the toxic protein, you can see that after treatment, the protein level go down and remain down for the rest of the period. The placebo group remain high, but then when they got the treatment, they lower as well. And you can see the same with the neurofilament light chain, which is a marker for neuronal degeneration. The level of that go down with treatment, and when the placebo group got treatment, it go down as well. So far, grip strength also sort of stopped progressing. Survival seemed to be higher in the treated group, not at 6 months, but further out. So basically, the initial study was a failure because it didn't meet endpoint at the pre-specified timeline. But when you look out longer after a year, it actually did. And that was summarized recently by Dr. Miller at NCALS. The interesting point about this is the neurofilament markers. Here is a group of patients who are at risk. These are patients that we know to have the mutation, and we know that at some point they're going to develop the disease. So what they did was to track neurofilament light chain, and you can see that prior to the onset of symptom at time 0 here, the neurofilament had already increased. So that's an early marker. Remember that there's so much redundancy built into your motor system that you pretty much have to lose about half of them before you actually got symptoms. And once your patients show up to you, even when they first develop symptoms, they already lost half or more of their motor neurons. And what you're trying to do now is fighting a losing game. So the sooner we know, the better we're going to be off, because you want to preserve those neurons and not allow them to die out. And so Biogen is doing this ATLAS study where if you have a mutation that's going to be, evolve into disease, they will track you along. And as soon as your neurofilament light go up, they're going to start treatment. Or if you start to have symptoms, they will start treatment. And we'll see over time how those patients do in terms of early interference. Here's an interesting recent study that tests high-dose methylcobalamin in early-stage ALS. Pretty short study, only about 16 weeks, but you see that there's a separation between the placebo and treated group very early on, about 4 weeks or so. And by 16 weeks, or 4 months, there was a clear almost 50% difference in progression rate. And the dose is 50 milligram IM for 16 weeks. I want to shift and talk about current clinical trials. So here are a schema of where things can go wrong. Every point along the path here, we have found abnormalities in experimental models. And we also know that there's other issues in terms of muscle and nerve communications and so on and so forth. So here are the different ways that we have been devising to, hopefully block one of those points and prevent the progression to self-death. And here are the current pipeline in ALS trial in the US and Europe. And we have some pretty early phase, and we have some phase 2, and then we have a bunch of phase 3, and then we have the platform trial, which I'll talk about in a moment. Unfortunately, in the last year or so, we have got some really bad news. The X represent all the trials that didn't show a positive results. So several studies have shown that complement inhibition didn't make any difference, blocking the neuromuscular junction or improving it didn't make any difference. Here are the cells therapy. We know that the neuron is so what they do is they take your bone marrow stem cells, they modify them so that they produce neurotropic factors and then infuse it back to you. That didn't make a difference. We know that the ASO study for C9orf72 mutation didn't make a difference. So a lot is being done in terms of redesign the trial pattern. So this is what we call a platform trial. So the old way of testing things that we test them separately and maybe serially. So if you want to test a drug, you recruit a bunch of patients, you randomize them 1-to-1, and then you run the study and then the next study coming in. So if you want to do, if you want to test 10 treatments, it's going to take you 12 years, 2,400 participants, and 1,200 of them are going to be on placebo. But if we do a study design where we test, whoops, sorry. Can you bring it back? So if you test 4 different drugs at the same time and use a common placebo, then you can minimize the number of patients who are going to be on placebo. Here, so basically you have 4 different drugs tested at the same time. You have 1 common placebo. So that way you can do a lot of trials faster. And if you do it this way, it takes you 4 years to do 10 trials, and your number of participants required is much less because you're sharing placebo. So that's the pattern that we're going after now in trials. And that's what believe it or not, that's what cancer treatment trials are all about. They use this whole protocol. Quick words to finish up about non-pharmacological treatment for ALS. So here is the normal energy demand situation. You take in enough to store and also to spend. In ALS, your energy intake going to go down, so you can't store and you can't meet your metabolic demands, which is actually increased during ALS. So as a result, you're getting worse and worse in terms of your function. So that's a study that looked at high-fat, high-calorie supplementation to see that make a difference. And you see that it actually doesn't make any difference in the whole population, but in those who have a fast progression, defined as more than 0.6 points per month decline, then you can see that there's a difference in survival. We also did something called respiratory strength training. So this is basically a device that you blow into, and you can set the resistance in here. And basically, it's physical therapy for your throat and respiratory muscle. You can buy this device on Amazon for pretty cheap. And the patient do 5 sets of exercise, 5 repetitions each time throughout the day. And we actually measure the patient after 16 weeks. And what happened is that the patient who was on it actually improved their mean expiratory pressure from 106 to 127, a 20-point gain, versus the sham where they actually blow into thin air, loss of 0.1. So that was highly statistically significant. And other secondary measure was also met. And when we look back at these patients, of the time that require them to get to requirement for non-invasive ventilatory support, the group that was treated with actual exercise actually took longer to get there than the sham control group. So as you can see, we made major headway. We still have a lot of steps to go. And, unfortunately, as you can see, the previous graph where there are so many points where things were abnormal, you can imagine, correcting one of them, how do you assure yourself that you correct everything? Or if correcting one is enough? And then when you run trials, you don't know which of your patients have, an antioxidant problem or something else. So those are design challenges that we're going to have in the future for ALS trial. Thank you very much for your attention.